So as you can imagine, I guess, I see Griffith University as a big machine. It contains many people, many areas of research. And within that, university sits different research institutes. And one of them is what we call GIER, Griffith Institute for Educational Research. And that brings together all the researchers who are interested in children and learning and education and adult learning as well. And within that is our little research group. So we have a group called Research in Autism and Developmental Disorders. And we are a group of only 8 to 10 researchers, and we've got about 10 PhD and master students working with us, all looking at work in the autism area. And within that, we also have what people are used to hearing, which is the Autism Centre of Excellence. And so I wanted to give you a bit of context, really, because you'll see that the Griffith Institute of Educational Research, or GIER, are the people that host the Twilight lectures, and a series of them are about autism. And so it's a sort of us contributing into this cog, which fits into the bigger Griffith University research. And that's important to us because by being part of this GIER, we get to have excellent things like Jackie come over from the UK. So Griffith is helping us to improve our research by bringing over sort of world experts and helping us to improve what we're doing, but also because we want you to learn from that too. Jackie very kindly said she would come and present today and share her research with you. So I think thank you to both GIER and Jackie for enabling this to happen. So just within, to put this into a bit of context of things we do, we don't just research on our own, we research with you, whoever you are, you're sort of stakeholders, the people out there on the ground. So whether you're a parent, a teacher, in policy, we work with all of you where possible to not only gather data, which many of you do for us with questionnaires, but also help us to set the priorities of what we need to be looking at and what's important for you out in the real world. We also publish our work, and last time I presented, somebody asked me about when certain publications were going to come out, and if that person's here now, they're all out now, which is great. We've had in our small research group more than 30 publications in the last 2 years around autism and education, and one book, and Jackie's just finishing a book as we speak. And if you ever want to find our research, this researchgate.net, you can sign up for an account and access our research papers on there for free. So they're the last copy before we give them to the publishers, before we sign over our copyright. So if you see research that we're doing and you want to access them, that's your place if you don't have access through schools or through health centres. And as we all know, it's always good if you can't access an article on there, you can ask us, you can just, there's a request button. So we will happily send them to you through that way. And also we're very keen on training our next generation of researchers. So we have both PhD and Masters by Research programmes. And we've been, GIER has actually sponsored a new postdoc, so someone who's just finished their PhD, which is Megan, and we've stolen her from one of the Melbourne Autism Research Centres. So she brings with her a wealth of knowledge from there, and she's going to be doing lots of work with us going forwards. And I think she's going to do one of these next year for you. So you'll see on your desks we have left, or desks, chairs, we have left you a questionnaire. So if you've been to one of these talks, my talk, which we did in May, I left these out last time, asking you what difference are these talks making. So Griffith University is really happy for us to do with these talks for free if they make a difference. So we need to keep demonstrating to them the difference they're making. So please do fill them in. They are anonymous, and just tell us whether you're going to do anything different after hearing this talk today. And if not, then maybe what you'd like to know more to help you. There's just 4 questions. Okay, so if you can leave them on your chairs on the way out or on the desks on the way out, that really does help us when we go to people and say, can we book out this whole lecture hall, and can we get speakers over from the UK? It really does help us make our case. So just my last slide, we've got some really exciting things coming forward. So next year, I'm setting up with Megan what we're calling PACER, which is partnering with the autism community to enhance research. And we want to set up a group of stakeholders, experts by experience, as we like to say, teachers, principals, people on the autism spectrum, parents, anyone in the autism community. And we want to run our ideas by you, get your ideas on the priorities, get your ideas on what results mean, where we can be taking them, and how we get them out into the community. So we're thinking we're going to do face-to-face days every 6 months, but give people the opportunities to opt in to input in between. I will be putting it up on our Facebook page, as I do with everything, but there's my email. If you're interested, just drop me an email. We're always happy to work in collaboration with departments, schools, and we do lots of work with the Autism Hub already, who's at the back, always sitting at the back, keeping an eye on you all. But if you ever are happy, we give talks at schools and other partners, so do just email me if you've got ideas on projects you'd like to work with. And there's our Facebook page down there where I put publications, research ideas, interesting articles, infographics, anything I think might be interesting going forward. So that's enough from me by far. I would like to introduce Jackie Rogers. So Jackie has come over from the UK, where it is much colder and wetter, and about 3 degrees. So she's from the north of the UK, so it's probably -3 degrees. So Jackie's been leading a programme of research helping to advance the understanding about assessment and treatment of mental health conditions in both adults and children with a diagnosis on the autism spectrum. And one thing that stands out about Jackie for me is she's doing intervention. So she's really taking it forward, and she's got a lot of funders behind her to do that, which is fantastic. Jackie's been leading the first ever autism-specific anxiety questionnaire development, and is now doing the same for a version for adults, and also depression, autism-specific depression measure. She's also involved, she regularly works with children and families affected by autism, and is a patron of Sparks, which is a registered charity to provide help and support to parents of children with autism and related conditions. So she's busy, and I'm very grateful that GIR has helped us fund Jackie to come over here. So today she's going to be talking about her work on mental health issues, and particularly an overview on the research of depression and low mood as they relate to autism. So thank you, Jackie.
Okay, thank you very much. So good evening, everyone, and thank you to Dawn for that introduction, and also thank you to Griffith University and specifically GIER for inviting me to come over to Brisbane to spend some time with the team here. And I have to say I'm absolutely blown away by the fantastic work that's going on here, and I very much hope to come back and hear the next instalment. So this is home for me, Newcastle in England rather than Australia. It's the most northerly city in England. It's a region of castles and bridges and beautiful countryside, but also very, very cold weather. So it doesn't often look as glorious as this. And it is about 3 degrees during the day at the moment. So my husband was telling me how he was scraping the ice off the car this morning. So I'm very pleased to be here on a number of levels. As Dawn has said, I work in Newcastle University. I'm part of the clinical psychology programme there, and I'm an autism researcher, and my specific interests are mental health in autism. And what I thought we might spend a bit of time thinking about today is depression and low mood as it affects people on the autism spectrum. This is a relatively new area of research for autism. Mental health has really been on the agenda for autism research probably only for about the last 8 years. Within that time, there's been a really rapid development of research and understanding, which is fantastic. But we still have a long way to go. You know, we're late to the party, as it were, as mental health researchers in autism. But I'd like to share with you a bit today about what we know specifically about low mood and depression. So I'll talk a little bit about the kind of prevalence rate, so how common is depression and low mood in both children and adults on the spectrum. And then I want to spend a bit of time thinking about actually what do we mean by depression and what do we mean by low mood, and do we mean those things in the same way when we think about them in the context of autism. So we'll spend a bit of time reflecting on that. But I also wanted to spend a bit of time sharing with you some of the some of the ideas that we've had as a kind of clinical academic research team about how we might support individuals on the spectrum if they have low mood. So I'm going to spend probably the most of the talk today is going to be about kind of ideas to share with you that you might want to try out with the people that you're supporting. So I hope that kind of meets your needs and is helpful. We know mental health conditions are common in children and adults with autism spectrum condition. We did a large priority setting exercise in the UK in about 2016, led by the charity Autistica, who are a big research funder for autism research in the UK. And they worked with members of the autism community across the UK to identify the research priorities that the community wanted to work on. So, you know, what do you really want to know? What do you want help with when it comes to autism? And in a similar way to the ideas that Dawn has to share that kind of process with you, this was kind of nationwide. And unequivocally, mental health was number one. That was the top priority for the autism community. Not what causes autism, you know, not what the genetic background is to autism, but how can we help people on the spectrum with mental health? And that really reflects, I think, what we are seeing clinically when individuals on the spectrum are referred to us in our clinical teams, that there's a real need for us to get better at supporting autistic people with their mental health needs. The other thing that we know is that when mental health is an issue for individuals on the spectrum, often it's something which has been around for a long time. So we see the emergence of mental health difficulties quite early on. And this is just a graph from one of our London teams indicating kind of where parents first report suspecting that their child with autism had a mental health condition. And you can see kind of quite an early onset. And that's much earlier probably than parents of neurotypical children would describe mental health as occurring. We know in autism that both anxiety and depression or low mood are very common experiences. So to give you an example of that, for anxiety, we know that for typically developing children, neurotypical children, the rates of anxiety are probably around about 12% of the population, whereas for children on the autism spectrum, the rates of anxiety affecting kind of daily living, impacting on family life and daily life, are around about 50%. So the rates are much accelerated, and although there's less research on depression to date, we suspect the rates are pretty similar in depression also. Now, importantly, I think what we're seeing as people are kind of getting to grips with researching mental health in autism is we're seeing emergence of evidence that when people on the autism spectrum, both children and adults, are experiencing mental health difficulties, those difficulties might present a little bit differently from the way, say, anxiety or depression might present for a neurotypical individual, for someone without autism. And that's really important, and it's really important for us to understand this for two reasons. First of all, if anxiety or depression are presenting differently, if the signs and symptoms are a bit different in people on the autism spectrum, then we may need different and better assessment methods to be able to identify those experiences for autistic people. And if we don't have autism specific measures, we may miss important signs and symptoms, and people may go unsupported. So it's really important that we understand how mental health difficulties present for individuals on the spectrum. And in addition to that, if the signs and symptoms of depression and anxiety and other mental health conditions are different for autistic people, then that may influence the way in which we support those individuals. So we may need to tailor our interventions to make them more appropriate and suitable for those on the spectrum. So it's really important that we spend some time as researchers and clinicians actually trying to understand the lived experience of mental health difficulties for people on the spectrum. And of course, we know from parents and from autistic people themselves that their their daily lives are often more affected by those mental health conditions than by autism per se. So this is a real call from the community, I think. So I know Dawn did a talk with you way back in May about anxiety, which is one of my interests, but I'm going to focus on depression today so that I don't kind of repeat what was said in that talk. So let's first of all just kind of orient ourselves to what we mean by depression. And we all use the term probably quite frequently, but let's just spend a little bit of time thinking about what it means. Well, when we talk about depression, we're really talking about an emotional state in which someone feels a sense of helplessness, that they can't make things better for themselves. People might feel guilty about aspects of their lives and their experiences, feel worthless, hopeless. People who have chronic depression often feel a real loss of energy, so they can't kind of motivate themselves to engage with the outside world and to engage with activities perhaps that they previously enjoyed. You may see a loss of appetite in individuals who are depressed, a lack of interest in previously enjoyed daily activities, hobbies and interests. You may see a change in mood, so someone may be a bit snappy or irritable if they're depressed. And often we see sleep problems in individuals who are experiencing depression. So maybe sometimes problems getting to sleep, or kind of early waking and then that kind of lying in bed, not being able to get back to sleep with all these kind of negative thoughts running through your mind. So those are the sorts of things that we mean when we talk about depression. Now, depression is a technical term, it's a diagnostic label, and often clinicians are somewhat reluctant to give formal diagnostic labels to young children. And they may talk about low mood, and low mood is kind of the kind of subclinical level of depression. So someone who has low mood may also experience all of these features, but they may not meet diagnostic criteria, but actually if they're experiencing these features to the extent that it's affecting their daily lives, then that's important for us to try and address, irregardless of whether they have a formal diagnosis. So if someone is frequently experiencing low mood, then clinically we should be trying to help out. Now there are some, so they're the kind of broad criteria in the way in which you would describe depression for adults, but there are some signs and symptoms that seem to be particular to children who are experiencing depression. So when a child has depression or has low mood, they may cry more frequently or more easily than they ordinarily would, so they're a bit more sensitive than usual. They may be a bit more sensitive to criticism or being told off than they probably ordinarily would be, and a bit more irritable. You may also see changes in sleeping patterns and eating patterns in children when they have low mood. They may complain of kind of physical complaints, but when you investigate that with your general practitioner or an A&E, there's no kind of identifiable source, so they may talk about headaches or tummy bugs, etc. Importantly, of course, given how important social development is in the early years, you may see a child withdrawing from their social world, not wanting to engage with their friends as much when they have low mood, and being a bit more kind of clingy than usual with caregivers. And obviously these will vary depending upon the age of the young person. Like with adults, you may see the child presenting with a kind of pretty hopeless, helpless presentation. Oh, I'm useless at everything, I can't do it, I'm really bad, I always fail. Those kinds of narratives you might hear in a young person. And in more significant cases, a child may express thoughts about hurting themselves, or they may engage in kind of what seems to be quite reckless, impulsive behaviours. And young children may often seem to kind of regress a little bit if they have low mood, so they may become a bit more babyish than they were and seem to be acting a little bit younger than their age. So what you can see there are some signs and symptoms of low mood that we would maybe pick out and look for in young people that we wouldn't ordinarily see in adults. And similarly, there are some things that we might see in autistic young people or adults that we wouldn't necessarily see in the neurotypical population, and I'll talk a bit about those in a moment. So we know that depression, from what we know about the research, which is quite new research, we know that depression is common in children on the autism spectrum. The rates are around about 30 to 50%, depending on which journal paper you read, and that compares quite markedly, as you can see, with the rates we see in non-autistic children. And we know that depression is overrepresented in autism, even in adulthood. The research on anxiety in autism is kind of developed on a pace, a bit ahead of depression, but the research on depression is catching up. And that's really, really important, and hopefully that will continue. There is some evidence that perhaps rates of low mood or depression are perhaps somewhat underdiagnosed in autism, and there are possibly a couple of reasons for that. First of all, it may be what's known as diagnostic overshadowing. So individuals, taking their child with autism or an adult on the autism spectrum, going for an assessment, and the features and characteristics that we may in a non-autistic person see as low mood are being attributed to their autism. Well, they're behaving like that because they're autistic, rather than that individual being able to recognise that this is a co-occurring mental health difficulty that's separate from autism. And actually that's really important for us to recognise, because we do know that we can make a difference with mental health conditions in autistic people. It's not an inevitability, and it's not something that we just have to accept and say there's nothing we can do, because there's increasing evidence that there is things that we can do to help. So it's really important that we try and push forward to educate our healthcare professionals to look out for mental health conditions in people on the autism spectrum, and to actually understand what the differences might be. So if you think about the list of symptoms that I read out to you, sleep is seen as a problem in depression, and people who are experiencing depression often have really disrupted sleep. Most of you who are working with young people on the autism spectrum will know that often young children with autism don't sleep very well, and they may not sleep through the night. If you see a change in your young child's sleep patterns, and you're concerned about that because it may indicate that they have low mood, a GP or a healthcare professional might say, well, they're just, they're bad at sleeping because they have autism, because they're autistic. But as a parent or someone caring for that individual, you might be thinking, well, no, it's different. It's, that yes, they've always had a bit of a difficulty sleeping, but actually this is ramped up. This is something above what is normal for them. And so it's really important for caregivers to be thinking about, what's usual, what's typical for my child, and is there a change in that behaviour, and then actually communicating that to caregivers. One of the other reasons why depression may go underdiagnosed in autism is because of the unreliability of the measures. So I've already mentioned that most of the research and most of the clinical work that's being done is using diagnostic tools for depression, low mood, anxiety that were developed for typically developing individuals and validated on those individuals, and then they're being used with autistic people. And so in our team, we're doing lots of work to try and adapt or develop new tools that actually take features of autism into account, so that we can get better at picking up mental health conditions when they're present. So we see higher rates of depression associated with autism, and of course one of the really important questions therefore is, well, why? Why is it that we're seeing these higher rates? And the research is in its infancy in this, but there are some kind of candidate ideas about why this might be the case. We know that individuals on the spectrum often have have a particular cognitive style or way of thinking, which means that they can really think about certain topics in quite a lot of depth, and maybe get stuck on that topic and think about that topic over and over again. And we would call this a kind of ruminative cognitive style. Now, someone who has low mood and who has a tendency to have this cognitive style anyway may then get stuck on thinking about negative things. So there may be ways in which autism and low mood kind of interact with one another in unhelpful ways to keep that negative thinking going. And of course then we need to think about ways of breaking that cycle. And there's some evidence for that from the Unruh and the Patel studies there, but there's lots more work need to be done on that. So there may be kind of cognitive factors that make people more vulnerable to depression. And of course there are also external and environmental factors that we need to take into account. So the bullying that we know is more common in individuals on the spectrum will of course affect mood, as it would for all of us, and that may be a risk factor for low mood. One of the features that's come out of the research with the general population about vulnerability factors for depression is issues around social connectedness and loneliness. Lack of social connectedness is seen as a real risk factor for depression in the general population. And there's emerging evidence now from some research groups in the UK and also some groups here in Australia who are looking at social connectedness and the rates of loneliness amongst adults on the autism spectrum. Most of this work has been done in adulthood. And they have identified that a lack of perceived belonging or a lack of social connectedness is also a risk factor for people on the autism spectrum. So we can see that some of the patterns that we're seeing in the general population are playing out in autism, and then there are perhaps some other more autism-specific factors that we need to take into account. In addition, most of you will know that people on the spectrum have kind of sensory sensitivity, so some people might have quite big reactions to particular sensory stimuli which they find aversive or uncomfortable. That could be sounds, textures, particular patterns, etc. And work that we've been doing over the last couple of years with autistic adults at exploring their experiences of sensory overload, they tell us that this kind of daily bombardment of sensory stimuli that's really aversive or uncomfortable is absolutely overwhelming and really debilitating, just to have to navigate through a world that is kind of uncomfortable to live in and can of course affect your mood. So it's really important. There's not much work been done on the relationship between sensory processing and mood, but I think it is something we really need to look at. There's also some intriguing work that's looked at the relationship between this kind of hyposensitivity that we sometimes see in autism, so a kind of an attenuated response to external stimuli and mood. So people on the spectrum may often have kind of reduced reactivity to pain and to certain textures and certain sensory experiences. And there's some work suggesting that people who have a presentation which includes hyposensitivity may also be more likely to experience depression. But that relationship, I think, at the moment is poorly understood. And I think that needs a lot more explanation before we can really say that the kind of hyposensitivity presentation is also important. But we are working on that in our group at the moment. We also know that people on the spectrum often have difficulties with changes to routine and like the world to be a predictable place. And we've done some work on this construct of intolerance of uncertainty, so a really kind of aversive reaction to being in an uncertain situation. And if you find uncertainty difficult, the world is an uncertain place. Unpredictable things happen all the time in big ways or small ways. And uncertainty, if you're bombarded with it, like the sensory processing on a kind of a daily basis, can feel really overwhelming and frustrating. And adults on the spectrum tell us that kind of repeated exposure to aversive uncertainty can actually be really overwhelming and can lead to kind of low mood and feelings of hopelessness and helplessness. How can I manage when the world is so unpredictable? And of course we also know that individuals on the spectrum may sometimes experience social communication difficulties and find it difficult to sometimes make sense of their own emotional experiences and to recognise and make sense of the emotional experiences of those around them. Now, can you imagine a situation where you are in a complex social environment? There's lots going on, lots of people talking, lots of things you need to work out about how people are reacting, both by what they say and what they don't say, and how they react and the gestures they use and the facial expressions that they have. And if that's a really challenging situation for you, then the world will feel quite a confusing and overwhelming place. But of course, we're encouraged to engage socially at school, at college, in the workplace, and constantly feeling that you need to be working twice as hard as everybody else to make sense of what's going on in your world is going to be exhausting and lead to social withdrawal, perhaps, because it's just such hard work. And social withdrawal reduces social connectedness and increases loneliness. So we can see then some of the relationships between, some of the challenges that autistic people might be experiencing and the risk of low mood. Restricted and repetitive behaviours, as you'll probably know, are a kind of core characteristic of autism spectrum condition, and they come in two forms. So we see repetitive sensory motor behaviours, so the kind of spinning, hand flapping, tapping, kind of fiddling, motoric repetition. And we also see what are known as kind of higher order repetitive behaviours, which include things like adherence to routines, insistence on sameness, etc. What we've seen in our research is that when individuals on the spectrum are experiencing difficulties with low mood, their regular pattern of engagement in repetitive behaviours may change, but it can actually go in either direction. So in some instances we see a kind of disengagement with special interests or hobbies because somebody's just kind of feeling a bit down and they don't want to engage with previously enjoyed activities. Conversely, we can also see an increase in some types of repetitive behaviours, particularly those that don't involve kind of a social setting. So if someone has a repetitive behaviour, a particular interest, which they can engage with in a kind of on their own, then they're removing themselves from that social world, and you can see an increase therefore in some of those behaviours. So the key thing for those of us working with people on the spectrum, it's not really about how much or how little people are engaging in these behaviours. It's a change from what is typical for that person. If you notice a change, then think about what might be behind that change, and that's really clinically what we would be asking parents to do. So we've talked a bit about what some of the factors may be that may influence low mood for people on the spectrum, and I just want to kind of move on now to think a little bit about how therefore we might try and support people on the spectrum who are experiencing low mood. And I've just got some generic tips first of all before I go into some more in a little bit more detail. Of course, if you have significant concerns about someone's well-being, if they're expressing the desire to harm themselves or they're engaging in activities like that, then it's very important to seek medical help, and I would really advocate that you do that. Generically at home, if an individual has low mood, one of the kind of classic interventions is to try and get them to be a bit more active. So this is kind of behavioural activation, it's called in the trade, but we would be encouraging people to engage to kind of get up and out a bit more and to kind of engage with the world. So if possible, encouraging regular activities or exercise, whatever form that may take, would be something worth having a go at. And of course, again, with the caveat that we know some of the challenges of autism, trying to support, where possible, healthy eating and good sleep patterns is going to help everybody who has low mood, regardless of whether they have an autism spectrum disorder or not. For those of you working in the school setting who have concerns about the mood of one of your students, then there are simple things that you can do to maybe try and support that individual to not withdraw from that and to continue to engage in that school work. So providing them, if it's permissible and allowable, with things like extended time for assignments and tests, not open-ended extensions, but actually just kind of working with them to provide a bit more space. Breaking things down into manageable pieces. One of the kind of cardinal feelings that goes with low mood is a feeling of kind of being overwhelmed and it's all too much. So actually kind of taking things in bite-sized pieces might make things a bit more achievable, and then of course if you achieve something, that's reinforcing in itself. Helping to create realistic schedules so the goal doesn't seem insurmountable or kind of unachievable, but is something that can be worked towards. Cognitive ability can sometimes be impacted by low mood, so poor concentration is something that we often hear associated with low mood and depression. So trying to scaffold and support that by maybe providing additional copies of handouts or notes in the classroom setting can also be very helpful, because of course if you're finding it difficult to concentrate and then you miss important bits of the lesson and then you can't do your homework as a consequence, that just feeds into this negative perspective you have about yourself. So trying to break that cycle wherever we can. And of course, given what we are now learning about social connectedness and belonging and loneliness, in an appropriate way, supporting and encouraging socialising. And of course, given the issues that we've talked about in relation to the relationship between sensory sensitivities and mood, wherever possible, trying to kind of reduce that sensory overload and reduce that sensory noise is always going to be a helpful thing to do. One of the things that we encourage in our clinical work in the UK for young people who have an autism spectrum condition and a mental health condition is work around developing emotional literacy. We know that individuals on the spectrum, not everyone, but a great number of individuals often have difficulties recognising their own emotions and kind of putting the bits of the jigsaw together to understand the experiences that they're having. And they will also, as I've already mentioned, sometimes have difficulty recognising other people's emotional states, which makes the social world a really confusing and challenging place for them. So we often do work with young people and their families about developing what we call an emotional vocabulary or an emotional literacy, and this can be done in the school setting just as well as it can be done at home, and is actually a really cool thing to do with all children, not just children on the spectrum. So it's something that the whole family can potentially get involved with. If we can develop better emotional vocabulary, then hopefully that's going to help us to feel less overwhelmed by the world, because we understand what's going on a little bit better. And it will also help when we then try and introduce strategies and other techniques to alter mood, because it'll be easier for us to monitor how that's working. And it creates opportunities for social connectedness, because when you understand how somebody else is feeling and you can relate to them more easily in that way, that will foster better relationships. So there are loads of different ways that you can try and promote emotional literacy, and what techniques you choose will depend a bit on the age and the ability of the person that you're working with. So these are just some ideas that are modifiable depending upon those factors. One of the simplest things that you can do, and I would really encourage you to do, is just to model emotional experiences, but do it really explicitly. I think we sometimes assume that kids just kind of soak up all this information about how the emotional world works and how you recognise sadness and happiness and calmness and anxiousness. And often, some children will do that, but there are many children who really struggle with recognising those things. And there are many children, when they're experiencing those feelings, kind of think it's only happening to them, which would be a really scary thing to think, I've got all these feelings inside me and everybody else seems fine. So actually just talking about your emotional experiences can actually be really helpful for young children and for young people. So, I was really excited about coming to Brisbane, and so I had a really tickly tummy the day before when I was packing my suitcase, and that's how I knew I was excited, because my tummy was tickly. You're joining those dots for the children, so they think, I've got a tickly tummy, maybe that was excitement. So you're being really explicit about making those bridges. I was sad, and this made me not want to go out, and I just wanted to sit on the sofa and hide under a duvet. oh, that's how I felt last week. Maybe that's because I was sad. So just being really explicit about those links, because for some children it's not obvious when people are presenting in this way. Reflecting also about your child's responses and reactions. So being, really mirroring. I noticed you were really excited about Grandma coming to visit, and I knew you were excited because you had lots of energy and you were really bouncy and you were talking really quickly and you had a big smile on your face. Joining those dots for young people can be absolutely transformational for young people who just haven't managed to make that join those dots themselves. Talking about emotions is a really simple thing for us to do, but it can make a big difference. In addition, using naturally occurring play and learning opportunities, so play with younger children, learning opportunities, kind of getting down with the kids, the adolescents, and getting into what they're into, and actually using that space to create an opening to talk about emotions can work really well. So, there are very explicit games that you can play with younger children where you have a body shape and you ask, what does your body do when you're sad? And you can draw kind of a sad face or a kind of churned up tummy or whatever it is. Sharing stories with emotional content. I mean, that can be very simple stories with younger children, or it can be, the latest blockbuster with a teenager. What do you think that person was experiencing in that context? Sorry, my screen's gone off, so I'll have to turn around. We also can spend some time thinking about trying to alter mood in young people on the spectrum. So as well as trying to develop emotional literacy, we can try and thank you, Dawn. We can try and directly tackle some of the signs and symptoms of low mood and depression. Now, when we have low mood is an obvious candidate for us to try and address, and there are a number of different techniques that we can do to try and shift that low mood into a better state for the individual. Mindfulness is something which is really emerging as a technique for use in addressing low mood and depression in neurotypical individuals, but also there's a growing evidence base for its use in autism. And really what we're doing there is we're trying to help someone to kind of lift their mood by just being in the moment and thinking about what's happening around them and kind of, getting rid of some of those negative thoughts that they might have. Other techniques that we've used are things like a treasure box or a memory box, which young children often really enjoy doing. It can be fun, where you collect items. It doesn't matter what they are, but they're things that have positive, happy memories associated with them, and you have a special place to put them. It could be a postcard, it could be a cartoon, it could be something that has a particular smell. It doesn't matter what it is, as long as it's something which is associated with feeling calm and feeling happy for that child. And if you see that child is experiencing low mood, actually just spending some time with them looking in that memory box and talking about the things that are in there and why they're actually in there can shift low mood. In addition to that, we can use things like relaxing or uplifting cue cards. So if you're out and about, you can get a child to take photographs of places they like to go, people they like to be with, and you can create a little booklet of cards that they can actually look at. So there are lots of different things you can do to just try and get into that mood and shift that mood, and actually spend time with the young person talking to them about whether that actually was helpful or not, so that they begin to recognise that things that you actively do can actively change how you feel. And that can be, again, a transformational moment for some children who don't kind of realise that connection. In order to address some of the social issues that I've talked about that we know are associated with low mood and depression, we can kind of, specifically try and address social strategies to try and help and uplift mood. So here the goal of these strategies is, wherever possible, to try and help the child feel less isolated and encourage social contact and social belonging. The other things that you can do in the social milieu are to actually get children to try and encourage them to engage with other people and ask them, what do you do when you feel sad? they'll get some kind of top tips from doing that, but they will also begin to recognise that they're not alone and other people feel these experiences, and those experiences are better when they're shared. We also, with some younger children, use techniques like comic strip stories, where we will talk about introducing techniques to change mood and to address sadness in a way that's very concrete and visual for the child, so that they can then access those when they feel they need to. I've talked a little bit about how feeling down and feeling low can affect your cognition and your thinking, and so one of the other things that we would try and do with someone who had low mood is to try and kind of change those kind of negative thoughts, try and address those cognitions that are getting in the way for them. And in doing that, hopefully what we're then doing is we're tackling those feelings of worthlessness, the low self-esteem that comes with feeling down and feeling depressed. And we're increasing a sense of kind of mastery, and I can beat this, I can address the way that I feel. And there are lots of different ways that you can do that, and it will depend a bit on, of course, the age and ability of the person that you are supporting. With young children, we've used things like cue cards or prompts, so kids who really struggled in school and they'll get into school and then they'll disengage from lessons. Everything's terrible and I'm useless at everything and I just can't do it. And we'll help them to develop cue cards that they can actually look at, which will counter those thoughts, but in a really concrete way. And we'll ask them to read the words off the cue cards and try and work with their cognitions in that way. We can use things like reality check, yes, you have done this before. Can you think of a time when you did? Let's talk about that. So you're kind of gently challenging those negative thoughts. That can be quite hard work with children who have really low mood, but it is worth kind of persevering with it if it feels like it's appropriate. We also do things like we encourage families to build up an evidence base of positive experiences. So a bit like the treasure box. But in this case, where a child's really said, I just can't do it, and then you find that they can do a bit of it, or they can do something similar, keep the evidence, whatever it is, if it's a photograph, if it's just a piece of writing, if it's half a drawing, whatever it is, just put it to one side, because that is concrete, hard evidence that they can. And then the next time they say that, you can go, haha, but I have evidence that you can do that. And you're really challenging those negative thoughts, but in a way that is tangible. It's hard evidence. And that works well with some young people, because they often will forget the things that they do well when their mood is low. They can't retrieve those memories of success because they're feeling down. So having tangible evidence of that can be really helpful. And talking about evidence, so there is a bit of evidence now in the literature for any of you who are interested in the research papers around specific interventions addressing low mood and depression, and in some cases other aspects of anxiety, like anxiety and stress, in individuals on the spectrum. And as you can see, CBT and mindfulness-based therapies are the ones that have been most researched to date. And I'm happy to point you in the direction of those research papers. If anyone would like them, please just email me. Just before I finish, I wanted to share with you some resources that we've developed back at the ranch in Newcastle. And these aren't depression specific, but they're more generic materials that can be used by young people and adults on the autism spectrum if they want to engage in therapy. And what families and young people and adults often tell us is that they really find it hard to go to that first session with a therapist or with somebody to support them, because they're asked all these questions and they don't know what, it can be a very anxiety-provoking situation. And so we've developed what we call therapy passports, and there are a number of different versions of those. So there's a therapy passport for parents, where they might want to just have a bit of a think before a first session with a therapist or a counsellor or whoever it is about important things about their child. So does my child have sensory sensitivities? Let's write down what they are so the therapist knows. How do they like to communicate? Do they know about their autism diagnosis, etc., etc.? So you can just do a bit of thinking and write it down and then just give it to the therapist, either before or during the first session. When we passed this idea past some of our consultation groups, the teenagers were horrified that the parents would be doing this. So we then developed a passport for teens where they could do that for themselves, and that could be done in conjunction with the parents or instead of the parents if that was felt. But it's the same thing really, but it just gives teenagers and older children the opportunity to say it how it is from their perspective, which is of course very important. And there's a version of that for adults as well. A Few Things About Me for Therapy is the adult version. There's also a document, very straightforward document called Top Tips for Therapy, which provides guidance for therapists who aren't autism experts when working with autistic young people. So anyone who is an autism clinician or researcher will probably find this a bit too straightforward and kind of, so what? But those of us who are working in the community who maybe don't have an extensive background in autism might find some of those ideas useful. And so that's for the Top Tips for Therapy is for working with young people, and then the final document there, what autistic people would like therapists to know, is something that was put together by the autistic adults that we collaborate with regularly, and it's a similar kind of idea. All of those documents, as well as the anxiety scale for children on the spectrum, which Dawn mentioned in her introduction, are available from our website, free to download. So, please do have a look at them if you think they would be useful, and tell me what you think about them and how we might improve them. So I just want to finish by saying we know that when any child is feeling low, then they will be feeling irritable, overwhelmed, and outbursts are common. And as parents, as carers, as teachers, as caring clinicians, we want to fix that. We want to make these kids feel better. But actually, depression and low mood are complicated, and we can't put too much of an expectation on ourselves to just be able to fix it in the moment as much as we would like to. Supporting a child who has low mood is upsetting, it's infuriating sometimes, it's exhausting, and these responses are entirely reasonable, and it's really important that those of us who are taking on that role do take care of ourselves also. Thank you very much.
Thank you, Jackie. I think we're going to do questions for Kate and Jackie together at the end. So I get to introduce Kate Simpson. So Dr. Kate Simpson, or Kate, works at the Autism Centre of Excellence along with Jackie Roberts and myself. Kate's interest her current interest focuses on participation in life activities, and Kate's taken a real lead recently in our research on developing ways to allow children on the spectrum to have a voice in research. So as well as asking parents and teachers questionnaires, we're doing a very novel idea of asking children on the spectrum what they think. And so Kate's going to share some of the methods we've been doing that with and how successful they have been.
Thank you. Now this is going to test my bilateral coordination. Can I use the microphone and the clicker? So I might end up speaking into the clicker and trying to move the slides with the microphone. So that was great what Jackie said, and it was just so wonderful to hear her descriptions. And a lot of our research about mental health has come from, as she mentioned, using measures that have been used on typically developing children. And we know that children on the autism spectrum may respond differently, or it may present differently. So what we've done, or what we're trying to do, is hear from the child rather than and get their perspective, because we get perspectives from parents and teachers and professionals, which is great, but mood, anxiety, depression are internal things, they're subjective. They may not always be visible, or the signs that are visible may not always be interpreted as you're feeling. And so we want to get the child's point of view. Now, there's a number of reasons why there hasn't been a lot of this happening, or why we haven't seen this today. And one of the reasons, and this impacts not only on children on the autism spectrum but adults as well, is social communication. Now, social communication difficulties is a characteristic of autism. But what social communication is when you are doing an interview, you have an agenda that you want information about. And you know when you're pitching your questions where you're coming from. You're assuming that the person you're interviewing also knows where you're coming from, which may not always be the case. Some of your questions may be said in a way that isn't clear how, people, and this is particularly on questionnaires, and seriously, how many people have had to fill out a questionnaire and thought, I'm not sure what they mean by that question, because if I respond to it how it's written, that'll be very different to if I respond to how I think they're asking, because this is a question about anxiety. So, there's all that interpretation, which, just as a little squirrel moment of mine as I digress, is something to consider if you're writing assessments for kids in school or for anywhere, that your questions may not be clear enough for the kids to then respond with the knowledge that they have. And so, with multiple choice questions, there's always that sort of one that's worded in a tricky way that's supposed to assess your understanding of the topic, but often it's only assessing your ability to be able to interpret the question the way that that person meant, rather than assessing your knowledge of the content. So that's just a squirrel aside to think about. But with social communication, it's reciprocity in social communication. So it's not only your meaning being understood, it's when you're responding to a question, your response being understood. So we can have this disconnect where someone's asking a question that's not being understood or interpreted as meant, and then the person is responding to what they think was the question, which is totally different to where it was meant. And so the person who's asked the question is interpreting it based on what they want to hear, which could be completely different to what you started off, what you did. And wasn't that nice and messy for everyone? So basically, social communication could be really messy, and you could both not be understanding anything that's happening. The other thing with it is anxiety in the interview process. And so with kids, there's an anxiety there with being interviewed. Now, I had an experience recently that a colleague and myself, who will remain nameless, we were somewhere and a child wouldn't enter the room because there were scary grandma-looking people in there. Now, that was a little bit, must have been my colleague, not me. That was a scary grandma-looking person. But I sort of thought, okay, so that's scary for the child. But even if we're a high-five look-alike person, we are still often a professional coming into the thing, and that creates a power disconnect for the child. So they're in a situation where they go into a room with a special person who's going to ask some special questions about something, and you've got to answer. And so that adds stress, and you don't know what's going to happen. How long's the interview going to go? What are they going to ask me about? What do I have to do? So there's those things. Also, as Jackie was talking, difficulty in identifying emotions. So you might know that you don't feel comfortable about something. You might know that things are amiss, but you might not be able to connect those dots. You mightn't have the language to connect those dots. And then there's difficulty with retrospective accounts. So I know if someone says to me, think about a time that this happened, can't think about anything. It's gone. So, sometimes having to think about a situation can be incredibly difficult when you're just sort of told, think about or remember a time when this happened, and you're thinking, can't remember anything, and I'm stuck. So all of those things make it interesting working with children on the spectrum, and consequently there hasn't been a lot of work done with children on the spectrum to get their viewpoints. So what we looked at is, one of the things, there is some work on using computers. And so we thought, okay, let's look at using a computer-supported interview. The potential advantages of this is it reduces social anxiety because you're focused on the computer screen rather than the scary grandma-looking person. It reduces the social communication demands because the information is there on the screen. You've got time to potentially look at it rather than they've asked a question and it's gone. You can control the sensory environment. So what we did was we did some of our interviews using video conferencing. So the kids were at home on their own computer in their own safe environment doing the interviews. So, there's that situation, and you can put in visual supports into the computer. So our aim with colleagues at ACE was to create a supported structured interview in order to investigate anxiety and anxiousness in 5 to 8 year olds. So this is they're quite young, and it was sort of quite different. So we thought, okay, how are we going to do this? And so what we did was, being aware that difficulty thinking about situations, we looked at what are situations that have been identified by parents and teachers that create anxiety for these kids. And so we used this is research that we've done and has been published, and the parents used the Ask ASD, which Jackie and her team have developed, and she mentioned that one before, and the teachers used the school anxiety scale teacher rating. So from those, we came up with 12 situations where children, parents and professionals identified children experience anxiety. Then we thought, well, what are their responses? And as Jackie said, sometimes they don't have the language, they don't know. They may know something's wrong, but they might not know what it is. So we looked at parent responses on an open questionnaire, and we came up with 14 possible responses that were the ones that were highly that parents identified most. Yeah. So then we put it into a PowerPoint structured interview format. And the first thing we did when we had the interview is set up the ground rules with the kids. And it was, we're going to talk about some situations that some children have said that they experience anxiety. And there's no right or wrong answers, and we really made that clear. We also made it clear that you might not experience this. You might not find these situations create anxiety, and that's fine. That there's no right or wrong, and we kept going, there's no right or wrong things. But we also gave them a choice of whether they wanted to participate and whether they wanted to stop at any time or if they wanted to have a break. And I think that's really important, to give children the agency to be able to say, no, I don't want to do this. So then we showed them the response slide. And so these are pictures of the 14 responses, but we also said you might feel something else or you might experience something else. So it was so that they weren't locked into those things, that there was an option of something else. We explained what each of those were and asked for them if they, had any questions about it. So then we presented the situations for them. So we presented, how do you feel when do you feel anxious when you think you've made a mistake, was the thing. And if the child said yes, then it went to the response slide and then they indicated what they thought about that. Okay, sorry, and then at the end, after talking about anxiety with children for a long time, we thought, well, we can't really just say, well, thanks very much, now that we've made you anxious and you're thinking all about it, you can go home now. What we did was we got them, or provided them, the opportunity to do this on their parents and talk about, do you think your parents ever feel anxious in these situations? Actually, that was the high point and that was the thing that they liked most. So, situations most frequently identified were those when you're the centre of attention, when you don't know what people think of you, and when there's a change in routine. Use of responses was interesting. Children used between 3 and 8 different responses, and 3 children provided 3 or more responses to the same situation. So sometimes I might do this, sometimes I might do that, and sometimes I might do this. And so that was interesting. What was also interesting is that of the responses not selected, there was none, which probably doesn't make sense. So all the responses were selected at least once. And these are the most often selected. Now, I do something else was most often selected. What they said in it was different. So as you can see, I feel weird. They knew that something was wrong, but they didn't have the words or the language to communicate what it was. And so I feel nervous, I feel homesick. So there was a whole range of different feelings, but most of them were related to the language or not having the language to explain what it was that they were doing. One of the issues, or one of the things, and remember we were talking about social communication, being able to understand what's being said and being understood. The same thing applies to visuals, and we worked with a team, including an adult on the spectrum who helped us. We went through a lot of images, looking at which ones were represented what we thought that the words were. So that was one thing. How much were ones that the children could relate to? So we wanted the images to be of children, and we wanted them to be of both boys and girls. And probably the hardest one is that we wanted it to be discrete in terms of, for example, loud. I talk louder and faster. This was one of the images that came up with loud. And this was another image. Now the first one looked to me like they're loud and angry, and we didn't want them to be loud and angry because they mightn't be angry, they're just talking louder and faster. So you can talk louder and faster without being angry. Just when you're angry doesn't mean you talk louder and faster. And so we had to try and find ones that were just representative of that response. And angry was really hard because there's all these pictures of kids pretending to be angry. And you're looking at them and you're thinking, you're not angry. Like, that's not an angry, she's sort of off, and you think you're smiling and you're... anyway, they were confusing. Or angry was they were punching someone. And I thought, well, we don't want that because you can be angry without punching someone. And hitting someone was another response. So it was a little bit challenging, but so the ones that we got were the best that we could get for what we were looking at. So the other area that we're looking at, so that was done with 5 to 8-year-olds. So we're also doing some research with 10 to 13-year-olds. And we were looking at children's participation because there's, again, with autism, when it's people on the spectrum are compared with typical developing populations, it's often based on typical measures. And participation is one of those areas where there is that expectation that participating in more things and being more involved is better. And that may not always be the case or may not suit people on the spectrum. And so we wanted to hear what kids thought about participation. So what we did was we looked at, so there was 3 parts, and I'll try and do this make sense. What we did was, again, we did it on the computer, and we created a PowerPoint of what the first meeting was going to be. I recorded that and sent it to the kids before the first meeting. So they knew what was going to happen in the meeting. So they had all the slides that were going to happen in the meeting. They had the questions and what I was going to say in the meeting. So they knew exactly, there wasn't surprises in the meeting. They knew what was coming. In the first meeting, we talked about assent. So they were given the opportunity at the beginning and the end as to whether they wanted to continue on. We discussed, so what they were going to do, will help if I tell you that, then it'll make more sense. So what they were doing is they were going to record their participation in activities across a week period. And so one of the things that has been used is taking pictures and then talking about that. But what often happens is kids will take pictures across a week and then you'll come back and talk about it and, why did you take that picture? I don't know. And they won't remember. So what we got them to do is take a video and record in the moment what they were thinking. So it was, this is whatever the activity was, this is who I'm doing it with, this is how I'm feeling, this is what I think about it, this is why I'm doing it. What we went through things that they could record about it. So in the first meeting, we talked about the types of activities that they might include in it. We talked about the ethics around taking pictures and not including people and faces and privacy, and we had to discuss those issues and what to talk about. Then they went off and took pictures for a week, videoed, and then what they did, when they uploaded these videos, we went through the narratives of what they said in the videos, looked at what it was, looked at what we wanted to explore in more depth with them, and then created an interview format that we were going to use with them. Again, we recorded it and sent it to the kids before the session so that they could prepare themselves and they knew what was going to happen in the interview. And so each interview was individualised because all the children had different things. So the feedback from the kids on that one was they really enjoyed getting the PowerPoint of, like, the video recording of what was going to happen, because it helped them prepare and they knew what was going to happen. They liked having the choice to participate or not to participate, even though they participated, just knowing that they could choose not to if they wanted to, or they could choose to have a break. And they thought filming was fun. So that was our response. They found one of the children said they preferred taking videos rather than having to talk about it, like going and having an interview. And then what was interesting was some of the parent responses. And parents were talking about, and this, I think this is really important to highlight, that sometimes no matter how well you know your child, you still might misinterpret what they're doing or misunderstand what they're doing. And so one parent said, I've made judgments and interpreted several times through this project where I've thought something that's not what she's thinking. And then it was the loveliest thing for her when she talks and actually explains the way her mind thinks. I often expect her to be thinking a different way than how she feels. And I thought that was really interesting because, you know, parents do give a lot of information, but the children also need a voice to explain a lot of the stuff that they're doing. And so I want to thank the children who participated in this research and their parents, because the children were young and the parents were there for supporting them. And the funding, there are two projects. So funding came from Queensland Department of Education for the first project and from Griffith University Arts, Education and Law for the second project. And
my question is for Jackie. I just wanted to know a little bit more about hyposensitivity research that you've done. Was that based on younger children or teenagers?
So the work, does this work? I'll shout. The work that we did on hypersensitivity, so we did work on hypo and hyper at the same time, because as you know, individuals can often present with hypersensitivities in some domains and hypo in others. The research that we did was with parents of children 6 to 16, so it was quite a broad age range. And what we were doing in that work is asking parents to report on their child's mood and also their sensory profile, and we were looking for relationships between those two things and what might predict low mood in those individuals. And what we found was that children who were reported to have low mood also were reported by their parents to be more likely to have a kind of hypo-sensitive presentation. Now, one of the difficulties with that research, I think, and why I'm keen that we don't read too much into it, although it has been replicated by the Bitsika paper that was done in this country, is that it was parent report, and it may be that what we see in people who have sensitivity to the environment is a kind of an underreactivity to the environment. And what we see in people who have low mood is a reduced reactivity to the environment. So I think we need to disentangle whether that's a true relationship or whether we're actually kind of measuring the same thing twice. And that's really hard to do when you've got proxy report. Although parent data and reports are very valuable, what we want to do now and what we are doing now with autistic adults is going back to autistic people, and adults are more able to reflect on those experiences. So we're currently undertaking a research project with adults to see whether we can replicate that, but we're still collecting the data on that.
Hello. I just wanted to ask, I actually haven't ever heard much about the hypersensitivity. How does it differ in terms of the hypersensitivity, in terms of symptoms and how it arises?
Yeah, so we know very little about how it arises. So in the sensory profile, what you will see are behaviours that are associated with a hyper-reactivity to the sensory environment, and that's probably what most of us understand by sensory sensitivity. So sensitivity to loud noises, to particular textures, etc., etc. But there's also evidence that for individuals who have a kind of fluctuating sensory profile, they may also experience hyposensitivity to the environment, so an attenuated response to the environment. So a kind of lowered responsivity, and that will present in ways such as a kind of an underreactivity to painful stimuli. It may be an underreactivity to temperature fluctuation, so not seeming to notice the cold or not seeming to kind of, want to kind of cool down in really hot environments. It can also present in social context, so individuals will report kind of lack of responsivity to kind of social overtures, so calling a child's name and they're not turning to the name. And it can respond in a number of, so that hypersensitivity can be present in a number of different ways. It can be, one of the kind of classic ways to measure it is to kind of see whether a child will remove dirt from their face or whether they will seek out hand cleaning if their hands are covered in gunk or what have you. So it's kind of the opposite of hypersensitivity. But interestingly, for people on the spectrum, you don't get people who are one or the other. Individuals will present with both hyper and hyposensitivity to different aspects of the environment, which suggests that you might have a very fluctuating and kind of labile sensory profile. Does that explain? Yeah.
In that respect, I'd like to add that it's been my experience that both hypersensitivity and hyposensitivity are both responses to overstimulation.
Yeah.
Where there is too much stimulation in the environment, one mechanic can happen where you become unable to filter out sensory experience and it becomes too much.
Yeah.
And the opposite is you become unable to interpret any sensory information and you can't build upon it.
Yeah.
My question, however, is has there been any research into whether mental illness in ASC kids is at all because of the overwhelming confusion that comes with not understanding any significance of the social actions occurring around them?
So I think there's an emerging literature base looking at social communication difficulties and also alexithymia, as it's called, this difficulty in understanding kind of emotional experiences of others and oneself, and that those challenges may actually then underpin particular forms of anxiety, particularly anxiety in social situations, as you would imagine, so kind of social phobia presentation. So there is a growing evidence base that those sorts of difficulties can be associated particularly with anxiety. And then, of course, I guess if there's a kind of chronic exposure to those sorts of situations, that may then consequently lead to low mood, yeah.
Hello, I had a question about treatment and whether, we're looking at how depression may present or be diagnosed differently in people with ASD. What about the treatment? I mean, obviously we spoke about some of the supports, but if those kind of preventative supports aren't working, is there any indication that treatment should be different for an autistic person rather than a neurotypical?
So by treatments do you mean
medical treatments? So
pharmacological treatments. That's really not my area of expertise. So I'm not a medical doctor. So I know that there are that medication is prescribed for low mood and for anxiety in individuals on the spectrum, but that's not something that I am involved in the research for, so I would hesitate, I guess, to kind of talk about their effectiveness.
One other question then is, going back to your first slide where you showed where when depression is identified in children. Obviously, it's identified most often when they're very young. With the graph, does that mean that it's compounding and more kids are getting identified kind of throughout the age, or is it that there's a reduction in what autistic people are experiencing as they grow through their childhood teen years?
Yeah, so that graph was about mental health conditions generally rather than just depression, so it was kind of conflating mostly anxiety and depression because that's where most of the research has been. And what we're seeing is a kind of an identification of anxiety and depression in parents of autistic children at a very young age. And then, so this is asking about first identification. So that doesn't mean that by the time those children are older, that difficulty's waned. It's talking about kind of first identification. So we're seeing parents noticing those difficulties in their children much earlier than parents of neurotypical children. But those difficulties will sustain throughout childhood, so that they're not waning of their own accord. There's not a kind of natural drop-off.
Hi. Thank you for your presentation. I just have a question about the sensitivities again. So to people with ASC, it's very real what they are feeling, and it makes it hard for neurotypical people to understand that. So I have a daughter who has a sensitivity to temperature, whereby no matter what the season, whether it's winter, summer, whatever, she wants to sleep with the fan on the fullest setting with no clothes on. And that's how she feels comfortable to sleep. However, is it the physiological, like, is her body doing anything to compensate for, you know, like, I'm always like, oh my God, if I'm cold, she has to be cold. And then I go and lay her up with blankets, because if I try and turn that fan off, she wakes up. So in terms of like trying to keep her well, like, you know, is that something that we intervene with, or is what she's experiencing real internally as well?
Yeah, that's a really good question, and I think it's not one that we really think about a great deal in the kind of mental health field, as it were. I think with certain sensory sensitivities, we have to be careful about trying to make sure that people are well. So if your daughter's temperature is okay and that behaviour is what she prefers, but actually it's not causing her any harm or risks, and she seems to be able to maintain her temperature, then I think that's fine. But it is something I guess we need to be mindful of. So, a child who has a reduced sensitivity to pain, for example, may engage in kind of behaviours that may actually be harmful because they're just not noticing in the way that we would the signals like you shouldn't really be doing that because it hurts. So that it's a case of kind of monitoring that, I think, and just making sure that those sensitivities are managed well and are not risky in their own right.
Hello. I was wondering if you have any suggestions for the children around about the 10 to 13 age who are reluctant socialisers, and the parents say, well, we've tried all these activities, they're anti-sport, the noises, the groups, the skills are low physically, and often the parents have gone through so many different activities and haven't found that thing, and everyone says, oh, they'll be right once they find the thing that they love, and they look to you and they ask you for inspiration and suggestions, and I don't know what to say. I don't know where to direct them, and I feel quite helpless when parents get to that point of frustration, and they're trying to expand the social network but are having such difficulties finding the right activities. So I'm looking for ideas?
Okay, I mean, I'm not sure that I have the answers to that, but I do recognise, I can think of many instances when I've had those conversations with parents myself, and I think it is very difficult often to find things that children will be willing to engage with, and parents are the experts of their child, and they'll know the sorts of things that might be engaging for them. I guess if we're thinking about social connectedness as being something we want to promote, then we need to really, I think, understand what that means from the perspective of somebody on the spectrum, and that there may be other ways to get social connectedness that aren't maybe the kind of traditional neurotypical understandings of what that looks like, and that may make it more possible and accessible for young people to engage in those sorts of endeavours. So I'm not advocating this for this particular age group, but I know autistic adults that we work with talk very much about kind of social media and that kind of thing being a real benefit to them in terms of just being able to link in with other people within the community who they feel they have some kind of an affinity to, and that can be very reinforcing for them and very helpful for them. That's not something you necessarily want to encourage in the 10 to 13-year-olds, given the risks that come with kind of social media use, but trying to maybe think outside the box a little bit about how we kind of can promote that social connectedness in other ways. But I don't have any brilliant answers to that, I'm afraid. We just need to keep thinking. I don't know whether you've had any thoughts about that?
I think you have to be careful, and we're looking at participation of kids, is that that we don't have a neurotypical lens of what is the acceptable participation levels, because children on that might actually be more stressful for kids on the spectrum than not. Also, what they view as social connectedness may be very different.
Yeah.
And it's more what they're satisfied with. Like, parents may be wanting to do this, but what do the kids want to do? And is it meaningful for the kids? Or is it going to be just another one thing that I have to do that's going to stress me out, that's going to make me anxious, and then I'm going to be more exhausted? So, there's the conversations around what is meaningful for the child is important as well. And Jackie and I were talking this morning about the whole concept of societal pressure to make sure that your child is involved in so many things, or doing this or doing that, to be seen, to be doing. And we probably need to shift our mind in that sense. And I got a nod from some people. So.
We've got probably time for one more question, but I'm breaking the mic.
Oh.
Is this lady here? There's a few more hands up, but we can catch up afterwards. This lady had a hand up.
I just had a question. Do you have much to do with children on the spectrum who have multiple personalities? We've got a child who's 5 or 6. We've probably seen about 5 or 6 personalities. However, the child's reporting up to about 19.
Right. I haven't worked with children with multiple personalities on the spectrum personally. No, I haven't. Have no clinical experience of that.
I think we are about to get evicted from a room. Sorry, this lady is very much a challenge.
And we don't mess
but
with...
we do have a couple of thank you gifts for our excellent speakers. I'll pass it to you. So join me in thanking you.
Thank you. I'd just like to thank everybody for coming once again, and hope that you'll join us again next year. We'll have a number of events, and we've got some a newly graduated doctoral, she's a doctor, and she'll talk to you about a communication project that she's been trialling during her doctoral candidature, and Megan, who had to leave. she'll talk about her work next year as well. So thank you very much for coming, and I hope you have a very restful Christmas.